Okay. Good evening, everyone. My name is Dr. Pankaj. I'm a consultant in critical care, presently practicing in Hyderabad. And thank you so much for joining today. And welcome to future critical care physicians and future leaders. So today's topic will be a relatively straightforward topic. It's ventilator-associated pneumonia. So let's start. So the presentation will be break up into these parts. So we'll just try to understand what is ventilator-associated infections, why do we need to know about them? Primarily the disease burden. We'll just have a detailed understanding of the risk factors, the diagnosis and treatment, specific measures and prevention. That is the WAP bundle. That is where most of your likely questions would be coming in, and a few recent advances just as a for completion. So before we start anything about ventilatory associated pneumonia, we should also know what's the difference. So what is hospital acquired pneumonia? So that's why typically the question might come. So what is hospital acquired pneumonia? Is a pneumonia that develops 48 hours or more after admission and did not appear to be incubating at the time of admission. So this primarily says that any patient in the hospital who did not have an infection or did not have a pneumonia at admission but acquired it in the hospital. So this can be ventilator associated or any other kind. So it meant so that's the difference. So if you look at the definition of our topic right now, that is the ventilator associated pneumonia or intubated associated pneumonia. It is a pneumonia that arises from after more than 48 to 72 hours after endotracheal intubation and is not incubating at the time of admission. So that's a very clear understanding. This is a person who has been intubated. There for hospital acquired, it was who was hospitalized. So if it is hospitalized, he gets a pneumonia after 2 days, it is HAP, but he gets ventilated and then on the second day, let's say, gets intubated and then he catches another infection, then that will be a ventilator associated. So if the ventilator was in place prior to inpatient admission, then the ventilator day count will begin with the admission date to the first inpatient location. So again, the ventilator, the association is with the ventilator. So it doesn't matter whether it was in which hospital, your hospital or the other. If the patient was intubated and after 48 hours you do see signs of pneumonia, then that is likely to be that day count. Now, if there is a break in the mechanical ventilation, a lot of times we do extubate these patients or try to get them off ventilator. That is one of the or preventive models. So if there is a break in the mechanical ventilation occurs for at least one full calendar day, and the ventilator day count for ventilator association will start anew upon reintubation or reinitiation of the mechanical ventilation. So that is an important point to know. These are points, especially in terms of surveillance. So that is where, and in terms of KPI, so that is where you will be really needing it. But the typical, based on the bacteriological data, it is also divided into the early onset or the late onset. So early meaning obviously it's after 48 hours and up to 96 hours after ICU admission. So they are likely to be caused by the bacteria which are mostly antibiotic sensitive, such as Streptococcus pneumoniae and gram-negative bacilli or methicillin susceptible Staph aureus. And they're usually, because they are more of antibiotic sensitive, tend to have a better prognosis. Late onset usually occurs after 96 hours. They are most likely caused by the multi-drug resistant pathogens, and those typical culprits are the Pseudomonas aeruginosa, Acinetobacter baumannii, methicillin resistant Staph aureus or the MRSA, and are because you are dealing with more multi-drug resistant pathogens, you have a higher morbidity and a mortality. Now, to understand the disease burden, the International Nosocomial Infection Control Consortium, or INICC, observed consistently higher VAP rates in lower and middle income countries over the past 2 decades. So that, yes, because our healthcare is not that developed, so yes, those numbers would be possible. And the INIC report from 2002 to 2005 indicated a VAP rate of around 24.1 to per thousand mechanical ventilator days, now gradually reducing to 11.96 in the recently covered data from 2015 to 20. So definitely things are looking good. So we have at least cut down by more than 50%, but we have a long way to go because the VAP rates in the USA, if you look at the CDC numbers, they are at almost at 1.1 per thousand mechanical ventilator days. So especially in medical or surgical ICU. So we have a long way to go, but definitely things are improving. And the patients having VAP, why are we really worried? Because the patients having VAP have an attributable mortality of 13.5%. So that is a significant number and we need to be careful. So this is a picture primarily showing the data, especially in Asia. about the prevalences of for in the WAP. As you can see, most of the red dots, quite a few are there in India. But this is a slightly older data. But yes, things are definitely on the improving trend compared to this. Now, if you look at the typical organisms, as we discussed few of them before, so based on the country income level, again, it might get divided. So mainly, you can see it's primarily the Acinetobacter, the Pseudomonas, and the Klebsiella, which are the number which are high even in the high income countries. But if you really note here, once it's a high income countries, typically the gram positive infections like Staph aureus tend to go up. So that is a typical trend that you would see. That's again seen here in the rates. And again, in terms of the tropics or the non-tropics, again, in the tropical areas, it's more the gram-negative, that is the Acinetobacter, the Pseudomonas, and the Klebsiellas. And in the tropics and the non-tropics, you will see a slight bump in the Staph aureus pictures. But overall, it's been pretty similar. So now the main function, that is the risk factors. So if you look at the risk factors, let's divide it into three parts. One is the risk factors related to the host, the risk factor to the hospitalization process, and with the drug therapy. So main, because the patient is the most important person in our care. So let us look at the patient. So any people with have advanced age, of course, they will have higher risk because of the decreased immunity and multiple comorbidities. Anybody with burns will have a loss of their skin, the protective areas, and high chance of aspiration and other challenges. Any chronic or pre-existing pulmonary diseases like tuberculosis, COPD, bronchiolitis, other usual suspects like cigarette smoking, immunosuppression, impaired consciousness, all these are risk factors. Impaired conscious coma, again, because you have a higher risk of aspiration and higher risk of you need a protective airway. So a lot of times you will get intubated. So that is a higher chance. Male gender tends to show up. Malnutrition, any neurological, neuromuscular diseases, again, higher chances of getting a secure airway or intubation. Organ failure, again, you might need an invasive ventilation if there's the oropharyngeal colonization for any reason because of poor care or poor malnutrition, all that, again, that might cause it. Post-operative acute respiratory failures, especially we see it in post-operative surgical cases, especially in peritonitis and all. So there might be some seeding and they may end up with this, or post-traumatic, post-surgical septicemia, trauma, or any underlying disease with their risk factors. So these are the typical usual risk factors, but we are looking more at the cases where it might be a higher risk of going for intubation, and if getting intubated, higher chance of getting an catching an infection. Risk factors with the hospitalization process, any invasive or processes which might break the bronchial mucosa, they will always have a risk. So any things like bronchoscopy, emergency intubations, endotracheal intubations will be higher risk. Until nutrition, especially through the tubes, could potentially use. Frequent changes of the ventilator circuit has been fine. We'll look at it as a preventive bundle later on. Gastric aspiration, that is a big risk. A higher frequency of antibiotic resistance, especially if there are, so you are more likely to get multi-drug resistant pathogens. Hospitalization for more than 5 days, so you know that's going to be higher, or it's a late onset possibly, or high chances that they might deteriorate and may need an invasive support. Long-term hospital and ICU length of stay, of course, they stay longer, they will have a higher risk. Long-term intubation, mechanical ventilation, multiple center lines may be a risk factor because you're always there might be some seeding. Reintubations, supine positions, thoracic surgeries, tracheostomy, long terms, again, especially if they are requiring ICUs, ventilatory support, yes, they are high risk. And then sometimes even transportation because there might be a movement of the tube and you might lose the protective barriers, and that could be a cause. Risk factors for WAP with the drug therapy, very important is the use of antacids or receptor antagonists or PPIs. So because they will create an alkaline milieu in the gastric area in the stomach, and any that will create a risk for increased risk of any growth of bacteria, and that if micro aspirations or any other challenges may cause VAP. So another big challenge is excessive sedation, increased IV sedatives, neuromuscular blockers. Again, all these will require an invasive ventilatory support. So again, that increases your risk for VAP. Any exposure to antibiotics, particularly to third generation cephalosporins, because prolonged use will induce the bacteria to become more resistant, and you get a higher chance of getting a multi-drug resistant infection. We already discussed the proton pump inhibitors, and even prolonged lot of red blood transfusions. So even that, because the transfusion related immunomodulatory effects have been seen, So you will try to, if there are going to massive transfusion or multiple transfusions, you will try to reduce that load as much as possible, and if possible, maybe even change to leukodepleted or leuko reduced blood cells. And of course, prolonged stress as a prophylaxis, again in the similar picture, the antacids will cause the same problem. Now, if you look at the routes of colonization or infection in these mechanical ventilated patients, so as you can see, it all starts with us. So it primarily it's our dirty hands and poor hand hygiene, which will be the main culprit. As you can see, the picture also starts from with us. And but again, there are other risk factors too, as we discussed previously, oral and pharyngeal colonization. Now, what is happening here? Because the tube is being used, all the secretions are going to get pooled in this area, and a lot of time they will get colonized because it's going to be affecting your oral and pharyngeal health. Because although there would be some amount of oral care and pharyngeal care happening, but it may not be enough at times, and there will be increased risk of catching infections. As we discussed earlier about gastric colonization because of increased use of antacids or PPIs, infected patients there because it might be cross contaminations. That is a big challenge that most of us in hospitals face. Handling of respiratory equipment, again, use of respiratory multiple devices. Again, that as we spoke about the bronchoscopy and the aerosols and any aerosols from the contaminated air. So all these are potential challenges where your infection might go directly into the lungs and possibly causing a pneumonia. And other therapies, as we said, sedation, paralysis, medications, positive pressure ventilations, semi-recumbent positioning, although it is a preventive, but again, because prolonged care, again, you might have a risk of those oral secretions coming down. But then again, the monitoring here, the biggest challenge would be how good the cuff is or the endotracheal cuff is. So usually, an endotracheal tube is a cuff tube. It will have a high volume, low pressure cuff. So it will majorly prevent any aspiration, but it does not prevent microaspiration. So it doesn't mean that it's going to be a foolproof thing. So maybe 98% of the time, most of your secretions are covered or prevented, but there will be a chance where through the folds of, because of high volume, so there will be few folds. And again, based on the change in the pressure of these, the cuff, again, it might, because you will feel aerated, you need to constantly monitor. So again, any change in that will cause or reduce pressure, as mentioned here, will cause that the some secretions may go down. Now, another important area is the bacterial biofilm, which gets formed because once it's a foreign material, the tube, so once it gets in, so it will try the all the secretions and all will create an environment where bacteria may want to form an area just similar to a center line. And that again becomes a challenge, and we might start almost immediately since intubation. That's why we always try to remove the tube as soon as feasible. And again, as we said, the tube also creates a direct contact. So all your protective mechanisms, that is the oropharyngeal, the laryngopharyngeal, all your lymph nodes, all those are bypassed and they go directly to the lung. So that's again a big challenge. So as we said, again, the immune responses again, because anybody in critical care, they'll be going through multiple challenges. So there will be increased, they'll, because of the increased bacterial infiltration, there will be increased edema and there are higher chance of migrating neutrophils. And all these male potentially even in the lungs might create a milieu for intubation for the pneumonia. So the commons, again, as we spoke about the biofilm, this is a picture to quite make you some better understand. So as we said, the intubation pressure would be one. So it has to be optimal around 20 centimeters, 20 to 25 centimeters of water. Again, if that, the position of the tube and the pressure has to be constantly maintained and monitored. And again, if any change in that, so you're aware you are increasing risk of intubation or increased risk of aspirations, and those could or any change or sudden position change, all those oral secretions might be get drained into your lungs. So again, the biofilm as we showed here. So all these also biofilms also, because they are going to constantly create a growth, they will always by chances may trickle down, and this dislodged biofilm may cause any pneumonia. So taking on. So bringing it all together, as you can see, the oropharyngeal, this glottic, the gastric and sinus secretions, all these bacterial colonizations may cause micro and macro aspirations reaching the lower respiratory tract. Inhalationally, that could be any handling of these drugs or aerosols may cause it. Very important, or the most important, is cross contamination via hands, disinfected or sterilized, or disinfected, sterilized, respiratory, improperly disinfected or sterilized respiratory devices. This will cause it. At times, you will see hematogen spread from distant body sites, especially who are in severe septic shock. So you will see that let's say somebody has come as a severe urinary tract infections. and it has gone into sepsis. That is, the infection is spread all over in the blood and is spreading everywhere. So it can always spread and come to the lungs, and you might get a similar cultures on the on when examination. Initial any embolization of the biofilms, which you already discussed. Any inspection from the surrounding lung area, that is a pleural space. So even that might spread and cause it. And because here, what is happening with all these areas, and now you are creating a tube where you're bypassing all the protective mechanisms, there will be a little bit of reduced humidification compared to a normal condition. So all these will create poor lower respiratory tract defense mechanisms, and this will always all together will cause a risk for pneumonia. Now, assessment of tools to diagnose MAP. So typically they are clinical symptoms. So clinical symptoms are any fever, any increase in secretions. That is what we'll be typically looking at. So these are the advantage of these symptoms are it's ineffective, it's rapid. You can check it. Any clinician can, of any grade, can check it, and can be found your foundation for clinical suspicion. But disadvantages, it is non-specific. So there are many reasons why secretions might go up, or there might be poor physiotherapy that might be causing the problem, overlap with other disease processes, compounded by other factors, and at times even inconclusive. So the radiological diagnosis can be done various ways. You can do a CT, so that will give you a very good image, accurate imaging, 3D imaging, but again, high radiation risk. You'll have to transfer the patient every time, and there'll be time delay, and very importantly, especially in our part of the world, it's cost. Again, chest X-ray similar to the CT, but yes, lesser radiation. It's easier to be done, rapid, less expensive. But again, because you're in the ICU, on possibly on the ventilator, you can only do a AP view, and you might get a poor limited positioning. It might be at times difficult to interpret, and they might be overlap with other disease processes. So you need to be really careful. Somewhere in midpoint, lung ultrasound has been coming up, especially in pulmo monitoring. So where again, lung ultrasound is portable, it can rapid, inexpensive, there is very minimal or zero radiation, and it gives you a better area of understanding with regard to the fluid and the any change in the lung tissue. So that you can always check for the surrounding areas also. So, but again, here with lung ultrasound, again, it's specialist training. It's all depends on very dependent on the user. So it again depends on the user skills and interpretation and limitation, especially in terms of body habitus, and if patients who have subcutaneous emphysema. I guess if you have completed your class on ultrasound, you know that if there is air, the ultrasound waves are not going to pass and reflect back. So there you'll not see really anything. And presently, the biggest challenge would be not a validated assessment tool, at least in case of PAP, but it is you validated quite a bit in at least in acute respiratory failure. So there you will really see it coming in. So microbiological diagnosis, we know the typical non-invasive methods not really used much, but invasive techniques, primarily you're taking samples from the lower respiratory tract. So they can be again divided into qualitative and quantitative. So qualitative are again simple and quick to identify the organism, but very non-specific. But quantitative, you're primarily looking at specifically at which organism, and you're trying to look at what is the kind of growth that is happening. So this is trying to differentiate between whether you're looking at uh, whether it is a colonization, where it's just, or is it an infection? So that is a big challenge that all of us or all of us daily face, whether to know it's actually an infection or just a colonization. That needs to be really helped. So what does help you in that? So it mainly the threshold values in the cultured specimens when we diagnose with this pneumonia. So typically lung tissue, although usually not done, but the values are more than 10 to the power of 4 colony forming units, then the per tissue it can be, you can take it significantly, but primarily it is done by bronchoscopic or non-bronchoscopic ways. So it is usually aimed for semi-quantitative methods. So again, you can check for the bronchial lavage. You can get a protective ball or a protective specimen brushing. So again, in this, if it's a ball, anything with ball, it's around 10 to the power of 4. If it is a protective brush, it is be 10 to the power of 3. But if you're doing a non-bronchoscopical methods, so if it's usually tends to be blind. So if you do a non-bronchoscopic ball, it will be around 10 to the power of 4. Again, if it's a protective specimen brush, it becomes again 10 to the power of 3. But if you're doing a direct endotracheal aspirate, that is just suctioning and you're taking them the blind secretions, then again here you will have to be take a higher value of around 10, more than 10 to the power of 5. So that is the important thing. Very common scoring that is used for ventilators with pneumonia is the clinical pulmonary infection score, or the CPIS. So here it's basically you're looking at multiple factors which you already discussed, like the change in the oxygen. In basically you're looking at the clinical picture and you're combining with the lab reports. So here it's primarily looking at the clinical, like the body temperature. So if anything above 38 or less than 38.5 or 38.9 will be 1 point. If it's more than 39, or if it's a high fever, or even hypothermia, then you get a higher point of 2 points. Then leukocyte counts, again depending on the microscopy. If it is within the normal range, it's usually zero. But if it is tends to less than 4,000, or leukopenic or leukocytosis is one, and if there are multiple rod forms or more than 50%, then again you might add to add a point. Again, as we spoke about the sacral secretions, so anybody with pneumonia, they will have change in their amount of secretions and the character of the secretions. From clear, it might become purulent, it might be colored like green and other colors, etc. So again, these secretions will decide. If sacral secretions, nothing is zero. With less purulence, it will be one, and abundant purulent will be two. Oxygenation, as I said, again, anything affecting the oxygenation. So that is the infection or pneumonia will definitely affect the oxygenation. So again, based on that, again you have the zero or two. Again, on the as we said, it will be combining. So we are looking at the imaging also. Any on the X-ray, if the infiltrations are not so much, it will be zero. Diffuse infiltration will be one, and if it's a specific localized infiltration, it will be again one. So again, those additional points need to be seen. And progressively, if you see an infiltration, you can again those points you'll have to add, and especially radiographic progression, ruling out especially heart failure and ARDS, then it will higher points. See, infection can lead go worsen the ARDS, and even the infection can cause cardiac septic cardiomyopathy and worsen the heart condition also. So you need to be keep a balance and always look at the alternatives as much as possible. And again, if you're getting a pathogenic bacteria, especially with moderate to high levels, and there the numbers will go. So if once you add all these factors with the clinical pulmonary infection score, and if you get a more than 6, it is generally accepted by most of the societies that it could be as treated as pneumonia. Uh, Usually, this is a summary of the biomarkers which we tend to use, especially for infection, trying to differentiate whether it's just inflammation versus infection. Not all of them are foolproof. Commonly used, which we use, are the procalcitonin and CRP. Procalcitonin, as you know, it's an acute phase reductant, primarily produced in the liver to respond to bacterial infections. It is a prohormone secreted from the serum from neuroendocrine cells in the lungs and intestine, and part of the SIRS response. Usually the numbers are undetectable or less than zero point zero 0.01. But again, you need to really know that these are usually produced by infection, but it is not very specific to it. And there are multiple non-infectious causes where the procalcitonin may be high. So always, if you really read into depth of it, the procalcitonin, again, they have varied levels depending on what kind of infection you're looking at. So there are specific cutoff values that you need to think of and generate based on it, where you can decide. But usually, yes, zero point 0.1 to zero point 0.5 is the usually risk that it could be infection. Then the CRP, which we spoke, it's a very non-specific biological marker. Again, primarily sensitized in the liver or mainly sensitized in the liver. So it's very liver dependent. So you need to be really careful in patient interpreting it in terms of chronic liver diseases patients. Normally, the health in healthy individuals, the CRP tends to be low, but again, as we said, it's very non-specific. So again, it responds to infection, trauma, surgeries, these any inflammatory process. The CRP can rise sharply. So you need to be careful. But CRP, yes, comparatively, it's cheaper to the procalcitonin. Now there are other methods like SRM1 or the soluble trigger receptors expressed on myeloid cells. So these are again biological markers which are being tried to differentiate between infection and inflammation. But again, these are not easily available, and again the cost factors will be coming in. So if you look at the just as a reference from all the national international guidelines, most of the guidelines primarily follow, if you see again, is the same picture, looking at the fever, increase in the core temperature, increase in the WBC, any increased secretions, increased oxygen requirements, and again combining with the radiological features, the microbiological features, and they usually tend to follow the CPIS scoring. So again, if you look at the UK guidelines, the American guidelines, again the ATS and the IDSA guidelines, and even the European guidelines, most of them follow a similar pattern, and not very much changes, maybe some minor changes here and there, but the typical pattern is the same. So if you really combine, and this is the reason it's very difficult at times because there's no one way, because everybody has a slightly different, mostly it is same, but at times the interpretation of all these factors may change. So if you really combine all of them together, so if you look at the treatment guidelines, so it will be patient, let's say, is mechanically ventilated. So that is your first, because you're looking for VAP or ventilator associated or intubation associated. So you need to remember ventilator here means intubation, not, so it is invasive ventilation. That is where it has to be ensured. So it is invasive ventilation. So in these patients, any respiratory deterioration or signs of acute infection, like we said, fever, leukopenia, leukocytosis, any change in the tracheal secretions, change in oxygenation, worsening gas exchange. So all these will combine, could potentially show that this could be VAP. So what do? We calculate the CPIS score. So if the score is more than 6 with the data, what we have is available, then you will commence antibiotic therapy. Let's not wait. But if the CPS is less than 6, so you will have to review the investigations, check for the sputum sample, repeat the chest imaging. You might need more. If you feel the X-ray is not enough, you may have to do, you would suggest a CT imaging. And now if they are more suggestive of VAP, then you will commence the antibiotic therapy. But if there are still no evidences, or you feel the growth, there's nothing much in the sputum, it's not grown much, but again, if you patient on long term antibiotics, again, for something to get a positive culture, it will be at times difficult. And on the imaging, if you feel there are other possibilities, like we said, heart failure or any inflammatory or post inflammatory changes, so then could be the other causes of pneumonia. So you may have to look for any other causes and keep repeating or reassessing the condition. So now that we have diagnosed, so it comes down to treatment. So again, if you look at the ICMR treatment guidelines for in 2022 for primarily HAP or VAP, that is a hospital acquired or ventilator associated pneumonias, typically the suggested regimens are, you will see, like it's more like the early versus late. So if it's early, more likely they will suggested like the third generation antibiotic like cephalosporin sulbactam, piperazine, tazobactam, either alone or with amikacin. So this is empirically. But at Lyme's, most of the times in a higher tertiary centers, these patients would already be started on these antibiotics. So generally, we will be ending up starting with the carbapenems, and you will have to combine it either with amikacin or with other higher antibiotics, even at times, depending on the history and if there are other cultures, you even have to go as high as colistin, polymyxin, or ceftazidime, avibactam. So these are the things. But special remarks again, levofloxacin may be an alternative. You may consider nebulized colistin, but again, with for carbapenem resistant organisms. But again, this is a little controversial. And again, very importantly, if the empirical therapy for mostly what we suspect are gram-negative infections, but yes, MRSA may be required, especially if the prevalence is more than 10 to 20%, or it's usually we see it post-influenza cases. They are higher risk for having gram-positive or even fungal infections. We need to always keep thought for that, and even may consider starting that too. So culture proved VAP, if there are, again, based on the culture, you will definitely decide on the culture sensitivity and take the call. If you are lucky, you will get sulbactam sensitive or cephalosporin sensitive Acinetobacter, but mostly at times with any Klebsiella, Pseudomonas or Acinetobacter, it's usually carbapenem resistant by the time you get, say, treat these cases. So you will end up either with ceftazidime, avibactam, or polymyxin, colistin, depending on the requirements. And as with, if there are increasing, if you're not really sure, but the patient is worsening and going to shock, then you'll just have to take the calls and go for a highest antibiotic. For MRSA, again, you can choose either, but all the suggested here is linezolid, but at time mostly it's in clinical we see it's primarily vanco or teicoplanin. So a few more points, as we discussed earlier, in susceptible cases, the levofloxacin may be used as an oral step down. Very importantly, pharopenem should not be used as step down therapy. This is an oral carbapenem, which is primarily used by the nephrology teams or the urology teams for the UTIs, but pharopenem as a step down therapy is not a great, especially in VAP and APP susceptible to carbapenems. Tigecycline is not recommended routinely in the treatment of APP, especially if it is Acinetobacter infections. You need to be careful, and it has shown increased mortality. So you need to be really careful in terms of using tigecycline. Now, if patient with susceptible VAP has septic shock and rapidly deteriorating status, as we discussed earlier, empirical coverage with MRSA and carbapenem-resistant gram-negative bacilli can be added along with the anti-pseudomonal beta-lactam. So this needs to be really focus. So you need to understand what are the potential uh, uh, infections or the bacteria which might be affecting you, and you will have to appropriately escalate before you lose time. So it is aggressive escalation and then aggressive de-escalation. That is where you need to really be care. You need to be aggressive. You need to be checked. And the antibiotic doses, again, because you are dealing with a sicker patient, so they need to be adjusted as per the GFR and ideal body weight, especially, and except maybe with patients with morbid obesity, then again you might have to change the formula. So again, depending on the condition, you will have to adjust the medications. And again, at times, if the infection, if they have augmented renal clearance, you might actually go continue with high doses initially, or even normal doses initially, and then maybe cut down. So that's where you'll have to see. What we spoke most importantly after for any infection is the de-escalation. So the minute you get the culture reports, especially if you are doing using multiple antibiotics, try to narrow the or reduce the antibiotic load as much as possible and do more specific in terms of the antibiotic dosing, and try to de-escalate as soon as possible. And again, the duration, again, not just the cutting the number of antibiotics down, it's also the duration. So the recommended duration is usually 7 days or 7 to 10 days, depending on the condition. But here again, taking call that if the patient is especially showing good clinical response, and if you feel there is no strong clinical indication like immunodeficiency, empyema, abscesses, cavitations, or necrotizing pneumonia, then you can taper it within 7 days. And again, very important is clinical picture. That is something you need to be checking every day. And decreasing procalcitonin levels will has shown a very high evidence-based method of or stroke for de-escalation of antibiotics and helping in conserving them. So this was a recent study which might get quoted in the exam, which is the regard WAP study. So this was done in 39 ICUs in Nepal, Singapore, and Thailand. So this they really compared individualized short course antibiotic treatment versus usual long course treatment for ventilatory associated pneumonia. So here the short course was individualized to around 7 days or even as short as 3 to 5 days. And a longer course is more than 8 days. So typically it goes to 8 to 10 or even at times to 14 days. So here the critical ill adults involving invasive mechanical ventilation for almost 48 hours who developed VAP and were treated with antibiotics and until the fever resolution came for 48 hours and showing some hemodynamic stability. So this was the methods. So if you see the results, so say in a 60-day composite endpoints for death, you can see it's been pretty similar, 41 to 44%. The mean antibiotic treatment, of course, because we're using a shorter course, it was 6 days. Here it was about 14 days. And most importantly, you can see the side effects. So because you are using the antibiotic for a lesser duration, the side effects are as low as 8%, while here it's much higher at 38%. So they did find that individualized shortened antibiotic therapy guided by clinical response was non-inferior to longer treatment in terms of 60-day mortality and pneumonia recurrence and associated with substantially reduced antibiotic use and side effects. So it was basically same. So if you can use it for as within 7 days, if patient is improving, so it is showing the similar result, and you can avoid the side effects of the multiple antibiotics. So now that we have just discussed regarding the treatment, the most of your questions, which I think one question we'll discuss at the end, we'll primarily be talking about prevention and surveillance. So that is where most of the critical care medicine questions do pop up in terms of ventilator-associated pneumonia. So the general measures for any prevention, first and foremost, is education and training. So if you don't really know what is ventilator-associated pneumonia, how will you treat? So you'll have to understand, keep re-teaching and reteaching the staff and the doctors with regard to educate about understanding what are the measures, what is about ventilator pneumonia, and especially learning about training measures as simple as even hand washing, where you'll have to really reinforce and get it, make it as a muscle memory, and that is something we need to really train our nursing and respiratory staff and even us, because if you see in terms of the hand washing compliance, you will see the worst offenders generally tend to be doctors. So that is something you will really have to be working on. Very important is surveillance. We'll talk a little more about it, and even the performance feedback. So whether all these measures are they really helping, and how what are the challenges the staff and the learners are facing. So you need to really keep a feedback and try to readjust and check what's happening. Very important is adequate nurse and respiratory therapist ratios. That's again a big challenge, especially in our requirement because of the high demand and the lack of a skilled labor that we get. So that's again the maintaining the ratios will be an important prevention. And as we discussed earlier, rational antibiotic use and limiting the amount of antibiotics, and the not just the amount and the duration. So both needs to be focused on. Typical question which might come in ventilator its surveillance is the VAE, or the ventilator associated events, or the surveillance algorithm. So this is shown very well by the NHSN guidelines. So here you can see the first form you have to mention that the patient has a baseline period of stability, or he was improved on the ventilator, where at least for 2 days he was doing fine or he was stable. And after that period of stability, you're saying that the patient has shown at least one of the following indicators of worsening oxidation. That is, there is a daily or a minimum increase in the FiO2 by zero point 0.2 or 20% in the over the daily minimum FiO2 for the first day is the baseline period, and is sustained for the next 2 calendar days. And there is an increase because the oxygenation is increasing. So what we tend to do is we increase the pressure along with it. So if you're feeling that the lung is getting bad or getting collapsed, we tend to increase the pressure and try to make the lung more open. So that's where you will the PEEP comes in. So if there's an increase in the minimum PEEP for more than 3 centimeters over the daily minimum baseline period for more than 2 days, so then you know that something related to the ventilator is happening. So here it is not still infection. There are so many other causes which might cause these problems, like inadequate sputum clearance, where it might got poor physiotherapies. It might be non-pulmonological causes. So all these can be the reasons. So it is primarily called as a ventilator associated condition. So once you get a ventilator associated condition, now on the calendar day 3 of mechanical ventilation, and within 2 calendar days before or after the onset of the worsening oxygenation, then the patient meets other criteria, like there is now fever. Now fever is coming in, or hypothermia, and you're again seeing leukocytosis or leukopenia. And then because of all this, most clinicians are forced or consider new antibiotic antimicrobial agent is started, and it is continued for more than for qualifying antimicrobial days. So then you might be counting on possibly an infection related ventilator associated complication. So once you are in the infection IR VAC or IVAC, then you need to really check exactly what is the infection that you're getting. So here, if there are more calendar on or after calendar day 3 mechanical ventilation, and within 2 calendar days before or after the onset of previous oxygenation, if one of the criteria are fulfilled, that is, you are getting a positive culture in any of these, like quantitative or semi-quantitative thresholds, as we discussed earlier, you're getting purulent respiratory secretions, and where containing more than 25 neutrophils and less than 10 squamous epithelial cells per low power field, and you're getting an organism identified on the specimens, especially in terms of sputum, endotracheal aspirate, bowel, lung tissue, or a protective specimen brush, that can be a positive. Or you're looking at any organism identified from the pleural fluid, which is taken from a recent chest drain within 24 hours, and looking at any other histopathology like an abscess formation, evidence of lung parenchyma invasion by fungi like hyphae, pseudohyphae, yeast, or evidence of infection with viral pathogens. Because that you are seeing at times, because the patient becomes his immune because response in terms of long-term care may get reduced, there is at times reactivation of viral infections like CMV, etc. And especially if you get a diagnostic for Legionella, or because you are in the ACs, they are high risk for getting Legionella. And your near expectations for, as we discussed, like influenza, respiratory syncytial virus, parainfluenza. So all these cause, sorry. So all these, if one of these criteria do come in, then you're primarily looking at a possible ventilator associated pneumonia. So these are the typical screening at per the present NHSN or the CDC guidelines. There are some other surveillance numbers that you can look at. So as we spoke earlier, as the VAP rates. So the VAP rate is per 1,000 ventilated days. It is usually calculated by dividing the number of VAPs by the number of ventilated days and multiplying the result into 100. So it is the number of VAPs or number of cases by number of ventilated days into 100,000, sorry, into 1,000. So that is where you will get the VAP rate per 1,000 ventilated days. Others are the device utilization ratios. That is how much of the ventilator is being used. So here the ventilator utilization ratios is calculated by dividing the number of ventilator days by the number of patient days. So these calculations will be performed separately for different types of ICUs or any location. So again, it's the duration or the device utilization will be the number of ventilator days by the number of patients. So again, showing up what kind of different ICUs will have different numbers, and we need to really check whether the standard numbers are happening or for some reason you're getting a prolonged ventilation. So these could be potential risk factors leading to VAP. So now coming to the more important factors, or where you are expecting more of the questions, that is the prevention. So in prevention, as most of you would have read about it, is the bundles approach. So what are bundles? So care bundles in infection are primarily prevention and safety. They are bundles in infection, prevent and say prevention and safety are simple sets of evidence-based practices that, when implemented collectively, improve the reliability of their delivery and improve patient outcomes. So basically, you're taking multiple interventions, using them together, and all of things working together to improve these patient outcomes. So now there have been studies for it. So Martinez Revio et al. In 2023 conducted a systemic review and meta-analysis on the effectiveness of these ventilator care bundles in prevention of VAP among mechanical ventilative patients. So this study, which included around 36 studies comprising of almost 100,000 participants, found that the implementing care bundles reduced the number of VAP episodes considerably, and the most commonly utilized components of ventilative bundles were the head of bed elevation and oral care. So this is the most common. Of course, hand hygiene is again an important factor. So again, moreover, the implementation of these care bundles was associated with decrease in duration of mechanical ventilation and the hospital length of stay, and all. But this was primarily seen only when the educational activities were integrated into the bundle. So again, as we discussed in the general measures, education and training is a very important, and it should be a continuous process. So only then will you maintain your numbers and the same. However, data regarding mortality outcomes were inconclusive. So you will see that most of the studies in critical care, at the end, whatever we do, regarding with significant mortality outcomes, they tend to be inconclusive, because you will never get a really case where you won't do really nothing is done, and where everything the intervention can be done. So always you will see not a significant difference in terms of mortality. So now looking at specific measures, so compared to the previous bundles where it was just 4 to 5 measures, now these measures have been expanded, and these are the updated recommendations as per the prevention of the ventilator-associated pneumonia as per the ISID, and this was done in June, and there's another update in recently in November also. So as we spoke about it, first and foremost, it is a ventilator-associated pneumonia. So treat the cause. So if you can circumvent the ventilator as much, especially for somebody coming with respiratory failure, if you can avoid the avoid intubation and prevent reintubation, more even the bigger risk factor of reintubation, then you will probably help the patient as much. And it has very high quality of evidence. So the picture here, it's typical if somebody has not seen, it's a high flow nasal cannula. We can discuss about it in other sections. Or you have the non-invasive positive pressure ventilation as so to be used as appropriate whenever safe and feasible. So again, primarily if you look at it, these non-invasive modes are primarily for a non-infectious cause, unless it is maybe a exacerbation of the COPD. But you can still manage in terms of especially immunosuppressed patients. You will see that a lot of times the non-invasive method is used, and high flow nasal cannula more and more is being utilized now, especially in terms of using for infective methods and to supply, and especially in weaning also. Especially patients with pneumonia, they need some additional support, because they will have a higher flow of oxygen to almost up to 60 liters compared to a normal nasal cannula with nasal prongs which you use, that is around 6 liters max. So almost 10 times you can give the high flow, and also has a very strong humidification. So that will really maintain and over maintain the picture and prevent infections. Then we have the ABCDF bundle. So that is the primarily what we speak about is the talking about the minimizing sedation. So we don't want patients just lying down on the beds and just sleeping. So if we can reduce the sedation, make them active, that would be the best method. So in these, it will be primarily avoiding the benzodiazepines and favor of other agents, because benzodiazepines tend to have prolonged effects and higher withdrawal reactions. So you need to try to avoid them as much as possible, unless yes, you do get a lot of cases with alcohol withdrawal and all, then you don't have a choice. Benzos are the best drugs there. Use a protocol to minimize sedation. So always try to maintain protocol and try to maintain the day-night axis. So try to keep the patients awake mostly during the daytime to maintain the diurnal rhythms and help them reduce their risk of delirium and other risk factors, and make them more active, and especially implemented a ventilator liberation protocol. So always try to look to, as we spoke earlier, try to reduce or remove the ventilator as soon as possible. So there is the ABCDF bundle as per the Society of Critical Care. So again, A is the assess and prevent for manage pain. B is for assess for spontaneous awakening trials and the breathing trials. Always keep looking for them. Have a very good choice of the analgesia and sedation as we discussed. Avoid benzos as much as possible. Again, look for delirium. Again, a big factor prolonging your hospitalization, especially in the ICU. So try to assess it and reduce and manage as much as possible. Early mobility and exercise very important, and even increasing importance is the importance of family engagement and empowerment, because more and more families, as you work now, you'll see they know quite a bit about it. They are becoming more accepting to what is happening, and they really understand the efforts that you take to treat them. So that really help us understand and help improve your outcomes. So as we spoke about early mobilization, again, I need to maintain and improve physical condition as much as possible. So always try to initiate exercise and mobilization as much as possible, and as the earliest stage as feasible, and could potentially decrease the duration of the mechanical ventilation, shorten the length of stay in the ICU, decrease the incidence of VAP, and enhance likelihood of patients returning to independent function. So you don't want them completely depend on the ventilator, because once you're on ventilator, the body just feels relaxed. It doesn't need to really exert any additional pressure, so it tends to go into disuse kind of an atrophy. It doesn't move, and that is the challenges that you will have to see. So try to keep the patient active and try to make him come off ventilator again, as we spoke. And once he's coming off the ventilator, again, these improved conditioning should be required, because we need to ensure that it doesn't go back on the ventilator. So always meant to maintain the muscle mass. So we'll just get a brief idea of why it needed, because if you look at the course of illness, usually the patient gets admitted here. So most of the time, if they are lucky, they will have an unassisted breathing. But if things get worse, they will get intubated. And hopefully, if we can reduce the time of intubation and they get extubated, and again, you are at unassisted breathing and discharge. But during this time, what will happen? There will be an increased weakness, because once you are unassisted, you are using your respiratory muscles, so activity is there. But once you go to go into mechanical ventilation because of sedation and neuromuscular blockers, so again, your respiratory muscles get to go become weaker, because they are going not being used as much, and then you're using a lot of sedation, neuromuscular blockers, which will increase your risk of weakness or ICU acquired weaknesses. So again, this is a big challenge, which will again, even though the clinical condition might improve, he might not be fit enough because of the poor respiratory muscles for extubation and discharge. So again, in the limb muscles, again, initially may not get affected, but as you see, as the longer duration of mechanical ventilation or dependence, limb muscles also will get wasted, and this again will really affect in the improvement and outcome of these patients. So as we spread, if you look at the injury mechanisms, again, it's excessive loading due to the respiratory failure. But along that, we see excessive mass. Initially, it's loading because you are unassistedly breathing, you're breathing hard. But here, what happens? You'll have excessive muscle unloading, or insufficient. Sometimes, if they are not synchronized properly, you are doing it. So insufficient muscle unloading may happen, and you might get acute and chronic weaknesses, and especially I spoke about pharmacological agents. So all these combinations will increase your risk for having ICU acquired weaknesses. So as we spoke about, always try to keep the elevate the bed head of the bed to 30 to 45 degrees. So it has a low evidence, but it is as you saw in the meta-analysis, one of the most common methods to be used. So here the head of bed elevation at 45, again, whether it's 30 to 45, one study said that elevation of 45 degrees was associated with the 35% lower incidence of VAP compared to 30-degree head of bed elevation. But again, 45 degrees at times you see it is not feasible for everyone. So you need to really balance it, and anywhere between 30 to 45 is a reasonable position for getting a good breathing. Because what happens? Because you want a upper position, you are trying to prevent any aspirations happening. You are getting the lungs to be more improved. You don't want any collapse or atelectasis happening in the lungs, especially in the lying down positions. If you are more head up, the lungs will be more open, so it will help you increase breathing. It will depress the diaphragm. It will promote chest expansion. So all this will helpful in early improvements of the case. Okay, so that is where a good head elevation position, especially in all ICUs, you will see most of the patients will be on head elevated to improve it. So next, another is the oral care. So always provide oral care with toothbrushing, but not with chlorhexidine. See, again, chlorhexidine was the mouth washing was the criteria in the older bundles, but now, as per the latest evidence, you have seen that chlorhexidine wash has been causing more mucosal damage and worsening the chances or increasing the chances of oropharyngeal colonizations and increasing VAP. So now the current guideline says try to avoid chlorhexidine and just use oral care with toothbrushing. If not the wash, you can always consider gel and 6 hourly with toothbrushing. This is a reasonably accepted regimen. Very important if you are having enteral versus parenteral nutrition, that is, if you are going to use the gut, if it's an oral feeding, always try to do it as soon as possible and try to avoid parenteral as much as possible because parenteral nutrition compared to enteral has not really shown a lot of promise. And again, they are increasing risk because it's an invasive line. You need a peripheral or a central line, increased risk of thrombosis of these lines, increased risk of infections, and it is not the normal or physiological way of feeding, right? So always try to maintain the feeding as physiologically as orally as much as feasible. Another at times is very important is change the ventilator circuit only if visible, soiled, or malfunctioning. So don't just randomly keep after 2 days, 3 days. At times, some ICUs used to do that. So just change the circuit. So even with a slight soiling. So very important. Only if it is severely soiled, visibly soiled, or there is a malfunction, only then change the tubes. And a lot of times these tubes are very resilient and they will generally not have any major challenges, especially taken from a standard companies. So again, the quality of evidence is high in this condition. So these are the main interventions that you look at. Supplementary interventions are use of selective oral or digestive decontamination, especially in countries or ICUs with a low prevalence of antibiotic resistant organisms. Again, the evidence here is high, but in our situation, because of the increased or uncontrolled use of unrestricted use of antibiotics, this always is not feasible. So SDD or oral digestive contamination is very not really helpful for us. Very important again, utilize endotracheal tubes with subglottic secretion drainage ports for patients expected to require more 48 or 72 hours of ventilation. So here, what is happening? You are getting a secretion. So this is a subglottic drainage port. So again, any secretions, as I said, oropharyngeal secretions will pull up around this tube, around the cuff, and they may trickle down. So these suction aids will help in all this clearing these subglottic secretions and have shown to decrease your risk of VAP. So that's a good or moderate quality of evidence. Again, another suggestion by the guidelines is saying consider early tracheostomy. Now, again, this is being an invasive ventilation. So it doesn't mean that any patient you will go for early tracheostomy, but you're trying to look at patients who are primarily where you need longer times of mechanical ventilation, like patients, let's say, coming with a neurovascular incident like bleed or ischem or bleed or acute stroke or a trauma, where you know that the severe traumatic brain injury. So these patients will require longer intubation trials, and rather than waiting for improvement, and you know that the problem is not the lung, the problem is the brain. So you will have to consider early tracheostomy so that you can at least wean off the ventilator as soon as possible and reduce some risk factors. So that needs to be cared. Again, an important factor, consider post-pyloric feeding like the nasovaginal or orovaginal tubing rather than nasogastric or orogastric tubes for feeding the patients with gastric intolerance or high risk of aspiration. So this is to be used only in patients who have a high risk of aspiration or who have very poor gastric tolerance. So barring those, anytime the enteral feed to be used, always use the stomach and use it only for these conditions. So again, that's the reason the evidence here again is moderate. You might have seen, especially in people who have worked in and the cities, you will see closed endotracheal suction systems. So this again, because you are in a closed system, you are avoiding any outside breach. So that's where Sani et al. And meta-analysis concluded that closed systems can significantly reduce VAP development compared to open systems. But again, closed systems as standard is not warranted because there are multiple individual factors and cost. So again, the biggest thing is cost. And again, you will see that with closed systems, as you work, you will see that these closed systems, although are will help you reduce VAP or at least reduce your disconnections and at least protect in terms of sepsis. But again, with increasing secretions and all, the suction system is not that efficient, and at times, and especially if the inadequate humidification, a lot of times the tubes do get blocked because of these. So that you need to be really careful, and you need to really be have a skilled technician to really manage these cases. Another important factor is the silver-coated endotracheal tubes. They may be used because, again, an important factor which we spoke about is the formation of the biofilm. So just like in the central lines, if you have the silver-coated or antibiotic-coated central lines, here again, a silver-coated endotracheal tubes will reduce the risk of biofilms. And again, here the evidence is moderate because, again, it's the cost which will come into play. So more than important what to do, another very important factor is what not to do or non-advisable interventions using ultra-thin polyurethane endotracheal cuff tube cuffs. So again, that will be has not shown a great evidence. Tapered endotracheal tube cuffs, again, not very good. Kinetic beds, not very good. Prone positioning, which had become very popular in with especially with the COVID pandemic. So that again may not be proactively only for WAP because the challenge here is the invasive part has to be reduced. It's not the positioning. So that will be a cause because at times prone position you will feel that the secretions might the oral secretions can be drained better, but no, that really doesn't work. And chlorhexidine bathing, just like with the chlorhexidine wash, has not shown any great interventions. Another important is stress ulcer prophylaxis. So at a lot of times you will see the standard prescription will have a PPI or Pantocid. So that is so again try to avoid these routine stress ulcer prophylaxis unless it is strongly indicated, like patients with trauma, with patients on steroids and burns, etc., where you have a higher risk of a stress ulcer. But if the patient gut is working and the patient is reasonably good gastric tolerance, so just stop the PPIs as soon as possible. Monitoring residual gastric volumes, so again has not shown great evidence. So this is something which you will see if you have worked in the ICUs, that a lot of times the feed is not cleared. You will see a lot of times the feed is come back and the nurse will come to you saying that we just aspirated after 4 hours and we have got gastroresidual volume of around 300 to 400 ml. So if you see the latest guidelines, especially when we talk about nutrition, I think later on there will be a section. So in that you'll see that monitoring residual gastric volumes has not been shown any help, and especially in these in prevention of WAP and also nutrition. So again, this has moderate evidence that it's not really working. And again, the use of probiotics. A lot of times people will suggest that use of probiotics will help you. But again, it works both ways. It's like a double-edged sword, and a lot of times it has caused more havoc. So again, avoiding probiotics would be the way to go. Now, these are all challenges that you will interventions where you're looking at a very high resource condition. But especially in a lot of areas, especially in our country with limited resources, you need to really think of cost effective measures. So the most cost effective is if you can assess for readiness to extubate the patient daily without contraindication. So every day, if the day the patient gets intubated, from next day you should ensure that the patient, all efforts should be made to ensure the patient is ready for extubation, especially if the primary part or the primary issue is settled. You try to extubate as soon as possible. Maintain the cuff pressure and volume at the minimal occlusive settings, as we discussed earlier, to prevent clinically significant air leaks around the endotracheal tube. So try to keep it around 20 centimeter water, and regular monitoring to be done, and ensure not just the cuff pressure, the cuff position also is a very important factor, because a lot of times the patient is moved in different positions. The tubes might be moved here and there. Patient is moved here and there. So a lot of times the change of position is a bigger factor than just cuff pressures. Try to minimize the duration of mechanical ventilation, as we discussed earlier. Try to minimize the duration of the ICU stays. If you can reduce him or transfer to a less or a high dependency unit, or even to the wards, if you can reduce the risk of cross infections, that always is a better. Very important, elevate the head of the bed to 30 to 45 degrees to help improve the lung functions, avoid atelectasis, and help in early weaning. Provide oral care with tooth brushing, but without chlorhexidine. We really discussed that, and that is something really needs to be followed. It is a more labor, it is an additional load on the nursing, but yes, but that is something very cost effective and help preventing, and always prevent condensation from reaching the patient. And the most important, I think, the most cost effective in all is the hand hygiene. So hand hygiene, as per the sepsis guidelines or your any society in terms of infection, will always talk about hand hygiene, and it has been from 1800s to now. It just stays the same. So always remember, the hand hygiene should have 5 key moments: before touching the patient, before clean or aseptic procedures, after any body fluid exposure, after touching a patient, and most importantly, after touching patient surroundings also, you need to clearly wash your hands, because that is the first and the fifth are usually the most common breaches that you tend to see in terms of compliance with hand washing. So looking at the future, so if we can see the future is again, if you ventilator associated, if you can just get rid of the ventilator, that would be the best. So there are sometimes people might say, sir, we can use ECMO. That is a way where you can do get away with ventilator. But a lot of times the patients are on ECMO or also on a ventilator. So they're very rarely they are on awake ECMO where without the ventilator support. So there are some newer technologies, although still in testing and research. So there is an Inspira ART machine where you can see it is a similar to ECMO machine where you can see a single axis here through the neck where it can take a blood. It will take the deoxygenated blood, be oxygenated in a more miniaturized way, and resend the oxygenated blood. So deoxygenated to oxygenated blood, just like a ECMO machine or a heart lung machine. So like a bypass. So these things will really help, and if we can miniaturize and increase the oxygen requirements or the oxygen delivery through these machines, yes, potentially we might reduce the need for an invasive ventilator. Yes, you may need some amount of positive pressure ventilation through the non-invasive modes. But yes, this might be a way to go. And even eventually, like there are some research going on implantable membrane lung. So if you can just avoid the lung itself, and there's an additional machine which will directly take care of it, but these are all still in research. So these are potentially sometimes maybe in the future, in few years, you might even see these kind of methods being used, and maybe even reduce your risk of a ventilator. So if you look at thinking all things together, it's all about working as a team. It's always preventing infection, especially ventilator associated or any infection in the hospital, is a team effort, and all the people involved in the care of the patient will be part of the infection care. So it's all in our hands, as we spoke earlier. Very importantly, handle the antibiotics with care. So always be try to narrow your antibiotic cover and reduce the duration to as much as low as possible, and try to keep it below 7 days, especially if there is strong clinical improvement and no other contraindications. Education training extremely important, and that is something we need to continue to do. And even if you have a senior staff with you and senior faculty with you, you need to keep retraining and relearning and reinforcing the preventive measures, and that needs to be continued. As we spoke about aggressive surveillance, so again that is an important factor. So till you look for it, you will never find it. So always keep looking for it. Always look at breaches in the care bundle and always look for improvements in that. And as we spoke earlier, good mobile early and aggressive mobilizations will really help you improve the overall patient outcome. So this is the last slide. So I just wanted to just discuss, because it's been a long, it's a really a dry topic in this ventilator pneumonia. So just a typical question which tends to come up in your critical care papers. So this is a question where a 63-year-old man with a past history of hypertension and diabetes presents with community-acquired pneumonia that progresses to ARDS. So on hospital day 2, you're seeing the mechanical ventilation was initiated and continuous enteral nutrition is initiated via 14 French nasogastric tube targeted to deliver 25 kilocalories per kg per day. So the question is very broad. Did you see that there's nothing specifically asked? You just mentioned the clinical condition, but this is how a typical critical care paper will come or a question will come. There will be multiple clinical conditions, and the question at times will be totally different or just leading up to it. So the question here is, which of the following strategies should be implemented to reduce ventilator associated pneumonia during ventilation? So the typical changes are: A is monitor residual gastric volume, B for elevate the head of bed, C is administer H2 blockers, D administer proton pump inhibitors, and E administer post phyloric feeding. So of all these, as we discussed earlier, so if you go one by one, so monitor residual gastric volume has not shown great benefit and it is not recommended, so that is out. Second, B, elevate the head of the bed. Yes, elevate the head of the bed to 30 to 45 degrees has shown one of the best measures to reduce VAP. So that is your one answer. C, administer H2 blockers again, and B, C and D, H2 or proton pump inhibitors. Any prophylaxis like antacids, like all these PPIs, should be avoided as much as feasible. And administering post-bariatric feeding, again, unless the patient has specific indications where you spoke about gastric intolerance or any other situations. So always try to avoid it. And the best answer here would be the elevation of the head of bed. So thank you so much for patient listening. And if any questions or comments, I would love to help you out. Yeah, thank you. The hand hygiene. Any questions? Yeah. So thank you so much, everyone. If any questions, you will always connect to me. Yeah. Thank you.
Thank you, sir.
Yeah. Thank you so much. Yeah. Chalo. Good night, guys.